I'm not sure there's a huge role for menin inhibitors in the treatment of high-risk MDS. So menin inhibitors seem to work in patients with rearrangements of the MLL gene, and those are not common in myelodysplastic syndrome. They occur occasionally, but not commonly. Also, in the current iterations of the classification of these diseases, I think they would, by definition, be defined as AML. But it gets back to what I said before, that what is high-risk MDS and what is AML? Well, we're calling it different things, but it's really all the same disease. So in those patients who might have a lower blast percentage and therefore have previously been called high-risk MDS, giving them a menin inhibitor, I think in the relapse setting would make some sense. We've shown in a paper that was recently published that you get relatively rapid resistance to menin inhibitors. That is, when you give a menin inhibitor, patients respond, but a large proportion of patients a few months later will end up developing resistance mutations that cause the patient to relapse. And the trick for any resistance mutation is you want to combine your agent with something else. So combine your targeted therapy with something that acts more broadly on leukemia generally. And I think that's what we're going to need to do with menin inhibitors, both for high-risk MDS and for acute myeloid leukemia.